We are live.
Uh, Good evening, friends, colleagues. I'm Jatin Sareen. You know me well, and I know you all pretty well. And we are here for a discussion on PARP inhibitors in two major malignancies, that is breast and ovarian cancers. PARP inhibitors have been there since last around 3 years or so, and we have gained a bit of experience, whatever small experience we each of us have. But we keep on have to fine tune ourselves to how to use them in a proper way. Much of data has come since we first used the PARP inhibitor in ovarian cancer, and now it is there in many other malignancies. So it's become a very important drug in our armamentarium. So first of all, I like to thank the sponsors of this meet, AstraZeneca, Intas, and Zydus Pharma. And without much ado, I would like to invite Dr. Kanika Sharma, who's a consultant medical oncologist at Max Hospital, Mohali, and she'll be speaking on choosing the right PARP inhibitor for patients in PARP-dependent tumors, and that is in ovary. I think Kanika is going to speak on ovary. So over to you, Kanika.
Thank you, sir.
Mm.
So good evening, everyone, and thank you for inviting me. Just so today I'll be talking about PARP inhibitors in ovarian cancer. So in the first line setting and in the recurrent and relapse setting. Just a minute. Yeah, is my screen visible?
Yes, ma'am.
Yeah, thank you. Yeah. So, as sir rightly said, it will be the choosing the right PARP inhibitor for patients with PARP-dependent tumors. That is, I'll be discussing about the ovarian cancer. So, as we know that there remains a significant unmet need for a newly diagnosed advanced ovarian cancer. So, actually, it's a dreaded disease. Even if the patient have a complete response, also we are still scared, and we actually counsel our patients also that 60 to 70% of them, they are eventually going to relapse, and we are also mentally prepared from the start go. But for the patients and for the attendants, it's very difficult because after all the treatment also there are high likely of chance of the tumor coming back. So when we see that the median progression-free survival is 10 to 18 months, and that may extend to 2 years, but actually within this time period, the patient either have a asymptomatic rise in CA-125, or they again starting having pain abdomen, or bowel obstruction symptoms again start appearing. So actually the 5-year survival rate is very dismal with 38% only, and there is a significant need for a better frontline treatment so we can actually progress this disease-free interval. So as we were discussing, why we need to increase this period, because the best response is from the first line of the therapy, and as we keep on using the other lines of the therapy, the PFS keeps on decreasing. And this we see in our clinical practice also, that the whatever may be the response to the first line treatment, but subsequently when we use liposomal doxorubicin or a gemcitabine regimen, the response is not that good, and we are just prolonging the inevitable. So the PFS, it keeps decreasing from 18.2 months to 10, 6, 5, and actually sometimes patient does not even respond or have a symptomatic reliefs on these treatment also. So there are a lot of therapy that are approved now in ovarian cancer when we talk. So starting with bevacizumab, Not that fond of that agent in ovarian cancer with a PFS of 4 months, but yes, in combinations with PARP inhibitor as shown in the PALO-1 trial, we can include chemo plus bevacizumab, or even in relapse setting or patient who have a gross ascites or a pleural effusion. So in these subsets, bevacizumab is a good agent and have shown benefit in these categories. Then come the olaparib. There are multiple trials that are done, which we'll be discussing in the first line setting, in the recurrent setting after more than 3 lines of setting. And it has shown a considerable advantage of giving the adjuvant treatment. Then we have data on niraparib. It's not available right now, but that is available irrespective of the BRCA status. Rucaparib, which is available, and in the relapse setting, we have rucaparib also. So there are 3 different agents that are presently approved, and they have their own, specific indications and individual toxicity profile and the, tolerance also. So when we talk about the olaparib, it is approved in the first-line maintenance therapy for BRCA mutated advanced ovarian cancer in the patient who have response to the first-line therapy, either a CR or a PR. Then in the first line maintenance therapy in combination with bevacizumab in the patients who have received bevacizumab along with chemotherapy, and maintenance therapy for the recurrent ovarian cancer, regardless of the BRCA mutation status, also as shown in the study 19. Then niraparib, it is approved in the first line maintenance therapy for patients who have responded to first line therapy regardless of the BRCA mutation status, and in the maintenance in the recurrent and relapse setting. For rucaparib also, there is an Atheno mono trial that have been released for the first line maintenance also. Still only PFS data is there and the long-term follow-up is not there. But there is some benefit, and they have shown that irrespective of the BRCA status, though there is only, I think, 3-month benefit in the all treatment population. So, but we need a long-term data for the first-line use of rucaparib, and in the maintenance therapy, it is there after the recurrent setting. So when we talk about the pharmacological properties of PARP inhibitors, so they have a different bioavailability, their mean half-life, the way they are metabolized, leading to the different toxicity profiles of all the agents. So they differ in terms of these property, and therefore the data cannot be extrapolated from each one of them. Like if in this setting olaparib is approved, so you can't indirectly use rucaparib, which we do in some cases, but usually that is not the case, and each PARP inhibitors need to be assessed based on its approved indication and data. So they have the same mechanism of action, but they differ. So the affinity with which they bind to the receptors, the PARP trapping, and their pharmacokinetics, including their metabolism, and that may differ in the side effect profile of each of the agents. So when we talk about the olaparib, the usual dose in the tablet form, it is 300 mg twice daily. And I usually start with the full dose only, and then gradually decrease based on the toxicity, the most common being anemia in the first few months. And then you can gradually decrease to 250 mg BD or a 200 mg BD also. So when we talk about it, so it has more affinity towards PARP2 as compared to PARP1 with a half-life of 15 years. And it is actually metabolized by CYP3A4 pathway. So there are a few studies, that is the SOLO-1 and PALO-1 in the first line, that is the single or the combination with bevacizumab, and the SOLO-2 and the study 19 in the recurrent setting. And besides ovarian cancer, there is also approval seen in the breast cancer, in the recurrent setting, as well as in the maintenance in the BRCA mutated patients. That is the early breast cancer. Then in the pancreatic cancer, that is the POLO trial, and the profound trial in the prostate cancer. So and all of them have shown beautiful results with olaparib in all these settings. So when we talk about the PFS in these studies of PARP inhibitors, so that also have to be seen in these study, that in which setting they were used, what were the doses that are used, And what is the tolerance of these agents? So like olaparib, we usually use the tablet form only, but if it's in the capsule form, that is the 50 mg, and the dose is also different, that is the 400 mg BD, and they can't be used interchangeably. So that has to be taken care whether the patient is taking a capsule form or a tablet form. And the tablet is available in 100 and 150 mg form. And based on, so you have to see whether there is any liver or renal derangement. So there may be a starting dose modification needed in patients who have a moderate renal impairment or who are using a CYP3A4 inhibitor. So in that, the dose may have to be modified. So as we all know, initially we have to monitor CBC for any anemia, fatigue, nausea, and then these are usually seen in the first few months, and once they are stabilized, then the patient don't have that much complications later on during the treatment. And based on that, we have to see how to interrupt, whether we want to transfuse the blood or not. So when we talk about rucaparib, the dose is 600 mg BD, but again, based on the tolerance, we give sometimes 500 also and 400 BD also. So with all the PARPs inhibitors, CBC have to be monitored. With niraparib, blood pressure and heart rate has to be monitored because of the cardiac profile also. So when we talk about the results of these agents, so as you can see, the chart with the palo one also in combination with bevacizumab, there is a significant difference between the two arms when we talk about the BRCA mutated and the HRD deficient patients. And when we just solely talk about the BRCA mutated, so it's a beautiful result of around 20 months prolongation of PFS and the olaparib arm. And when we talk about the intention to treat also, so there is around 6 months increases there. In the single arm, that is the monotherapy maintenance, that is olaparib, it is not reached in BRCA mutated patient as compared to 13.7 months. So with the even longer follow-up also up to 2 years, the median PFS is not reached, and that is a very good result for the patient also, in which we know that 70% of them will relapse. But again, the BRCA mutation is very less. But when we talk about the HRD status, the percentage is now gradually increasing. So when we talk about in the recurrent and relapse setting also, that is the solo 2, that is there is a significant benefit in the BRCA mutated patient, that is 9.1 months as compared to 5.5 months. In that, and when we see the other agents also, that is the rucaparib or the niraparib also, so there is a very significant difference and the prolongation and olaparib arm as compared to the other agents. So when we see these studies, so as you can see, the study 19 that was done in the multiple lines relapsed setting. So there is a median PFS benefit irrespective of the BRCA status, that is 8.4 versus 4.8 months when the patient have received more than 3 lines of treatment, with a significant difference in the hazard ratio. When we talk about the germline BRCA mutated patients, so there is a significant difference, that is 19.1 versus 5.5 months in the olaparib arm. So as compared to the other, that is the niraparib, it has a very good results in the germline mutated, that is 21 months. Whereas rucaparib, it is 16.6 months with in the BRCA mutated arm. So when we talk about the solo to final data, even the OS data now, because there are long-term data available with olaparib also. So in all the studies, there is a significant OS benefit also in the olaparib arm, that is 51.7 months versus 38.8 months. Now the hazard ratio of 0.74. So talking about these figures in ovarian cancer, that to stage 3 and 4, it is a remarkable results. So when we talk about the US FDA approved PARP inhibitors in ovarian cancer, so olaparib, it is approved in the maintenance therapy in the first line setting. Then in the recurrent platinum sensitive ovarian cancer, in the germline or somatic BRCA mutated first line maintenance therapy, it was approved in 2018. And in combination with bevacizumab in the HRD positive patient in the first line maintenance. Niraparib, it is in the first line maintenance irrespective of the BRCA status, and in the HRD positive relapsed ovarian cancer also, it is approved. Rucaparib is presently approved in the maintenance in the recurrent. Based on the long-term methinomono, maybe the indications will change, we have to see. So when we talk about the different indications, so olaparib is the only agent that have been tested in all the subset. So it has effect based on the BRCA status, whether whatever may be the situs. So not just ovary, even in the breast, prostate, pancreas, the patient who have BRCA mutation, there is a benefit seen with the olaparib. So even we see in the breast cancer also in the patients who are mutated, the adjuvant olaparib, they have shown benefit in these patients also. So when we talk about the safety and efficacy, so right now we have seen the efficacy data, but now as we know that the PARP inhibitors, they are not very easy drug to tolerate, and the patients they have, and we eventually have to reduce the dose in majority of the patients, hardly any patient to tolerate the full dose. So olaparib, they have demonstrated a superior safety profile as compared to the other two agents, that is the niraparib and the rucaparib, and with the reduced odds of more than grade 3 adverse effects and treatment interruption. So as I was saying that after initial few months, there are not much side effects with olaparib in the long term. So when we talk about grade 3, 4 treatment interruption, dose reduction, so when we compare olaparib with rucaparib or niraparib, there is a significant favor towards the olaparib arm when we talk about the side effect profile. And when we talk about the efficacy data, so olaparib, they have the highest PFS in terms of number, although you can't do the inter-study comparison. But the good thing is that in the placebo arm, it is comparable. So it's not like the data is different between all the different studies. So when we talk about the placebo in stage 3 and 4, it is 5.5 to 5.4 months only in all the study. So if you can compare the study comparison also, so olaparib have a significant prolongation of that DFI period, that is 30.2 months, more than 2 years, as compared to 21 months with niraparib and 26 months with rucaparib. And even when we talk about the hazard ratios also and the median PFS also versus placebo, there is a significant benefit seen. As compared to the other grade 3, 4 side effects, so it is comparatively less as compared to the other two agents. So that is 36.9% grade 3, 4. Half of the patient, they required treatment interruption and dose reduction. So even dose reduction also a significant patient required, but after the first dose reduction, it is usually well tolerated. So when we talk about the compliance of the patient, so there are two things, that is the persistence and the adherence. So what exactly is the persistence? That is the percentage of the patient with no index PARP inhibitor regimen treatment gap of more than 90 days. That if there is more than 3 months, there is not a delay out of those with at least 6 months of continuous enrollment, that is the persistent treatment. And treatment adherence, if we see a fixed 6 months follow-up period, so more than 80% of the time patient should have adhered to the treatment. In between, intermittently, some gap may be needed. So if it is more than 20% there is a gap is there, that is a non-adherent treatment. So that has to be seen and discussed with the patient whether they are intermittently stopping the therapy or not. So these 2 points have to be taken care. So based on these points also, that is the persistence and the adherence also, as we can see these percentage are relatively higher with olaparib as compared to the other two agents, that is niraparib and rucaparib. And the side effect profile, usually there are hematological toxicity only in terms of anemia and thrombocytopenias. The other being the AML and MDS, not that frequently, and nausea and vomiting and fatigue, they are commonly seen. But as compared to the other two agents, it is less as compared to olaparib. So even in the documented studies of all these trials of olaparib and the niraparib in the first line setting, that is newly diagnosed setting, the grade 3 or 4 toxicity, it's almost half, that is the 40% as compared to 71% with niraparib. Dose interruption, half of the patients, they require dose interruption, dose reduction in 1/3 of the patients, and a continuation in only 12% of the patients with a single arm olaparib, and in the combination of bevacizumab, it is 20%. So in the recurrent setting, when we talk about, even we know that when we have given a PARP inhibitor, because it has an impact on bone marrow, even it is difficult for the patient to tolerate chemotherapy also after PARP inhibitors. So that has also be taken into account because of the recurrent anemia and thrombocytopenia. So if patient they progress after a PARP inhibitor, so even the chemotherapy dose has to be reduced. So with all these agents also, there are frequent discontinuation and dose reduction. It is relatively less in olaparib, and there are elevated AST and ALT. They are documented with rucaparib. So LFT has to be monitored with olaparib therapy, rucaparib therapy. So when we talk about the ASCO guidelines on the PARP inhibitors, so in the first line maintenance therapy, both olaparib and niraparib, they are approved. Niraparib is not available, but they can be offered irrespective of the BRCA status. And the patients who have responded to the first line therapy, so olaparib should be offered to patients who have a germline or somatic BRCA mutation. And in combination with bevacizumab in the patients who have responded to bevacizumab plus chemotherapy combination. In the second line setting, in the maintenance therapy, patients who have responded to platinum-based chemotherapy, it's basically an indirect indication that the patient will respond to PARP inhibitors also. And we can offer a single agent PARP inhibitor with no prior exposure, regardless of the BRCA mutation status also in the relapse setting. So currently they are approved in the 7 indications in 4 different tumor types. So we have 4 different trials, that is the SOLO 1 and PALO 1 in the newly diagnosed case, SOLO 2 and Study 19 in the relapse setting, then Olympiad and Olympia in the breast cancer in the early stage and the metastatic stage, and POLO and Profound in the pancreatic and prostate cancer respectively. And as you can see, all of these study, even the OS data, it is remarkable, as we can see with the PFS data also. So usually if there is a significant PFS data, so automatically we don't look for the OS data, but even with the long-term follow-up also, there is an OS results also with olaparib. So take-home message after this, that they are transforming the epithelial ovarian, fallopian tube, or primary peritoneal cancer patient outcome. They have approval across 4 different tumor types, and the especially in ovarian cancer in the first line and the platinum-sensitive relapse settings. Not all of the PARP inhibitors are same. They have a different toxicity profile. Different monitoring has to be done with each of them. And individual PARP inhibitors, they have some unique toxicity. So that requires attention and customization based on the patient's requirement. So thank you so much for your patient listening.
Thank you, Dr. Kanika. Well, that was quite an elaborate presentation of usage of PARP inhibitor, especially olaparib in ovarian cancer. I think we'll be taking all the questions and discussions in the other sessions. So without wasting much time, and I would request my speakers to kindly stick to the time. And I would like to invite now the next speaker, who is Dr. Mukesh Bansal, consultant medical oncologist at Alchemist Hospital. And he is going to tell us how to choose the right PARP inhibitor in breast cancer. So over to you, Mukesh.
Good evening, everyone. I would like to thank you, organizers, Dr. Jatin sir and the Astra, for interesting me with this topic. Can someone share my slides? Yeah. So I will be discussing choosing the PARP inhibitor for patients' PARP-dependent tumor, that is breast cancer. Next slide, please. So we will be basically discussing the background, the context setting, then what is the role of BRCA mutation in the breast cancer, targeting the BRCA mutation in specifically early breast cancer, and then summarizing the things. Next slide, please. So as we know that breast cancer is the most common cancer worldwide. Around 20 to 30% will recur where cure is no longer possible. So basically around 25 to 30% have a distant recurrences and goes for palliative setting. And around 9% of patients with HER2 negative disease have a germline BRCA mutation. Next slide, please. So coming to the Indian data, in 2020, up to 30% patients in India presented with early breast cancer at diagnosis. Obviously, in Western countries, the majority of the breast cancer patients are now being diagnosed in early stage or localized stage, while in India, the most common presentation is loco-regional stage. Next slide, please. So what is the current early breast cancer management? If we see in a nutshell, for the luminal A and B types, which are basically hormone positive and HER2 negative types, low proliferation type luminal A and high proliferation type luminal B, we usually go for surgery with or without adjuvant radiation therapy. Then based on the risk of recurrence, which can be decided by oncotype DX and other scores, we usually go for endocrine therapy alone or adjuvant chemotherapy. If we come to the triple negative type, chemotherapy usually preferred in the neoadjuvant setting, which may be anthracycline taxane sequence, and platinums may be added. And if the patient doesn't achieve the pathological complete response, then the current indications goes for adjuvant capecitabine. Coming to the HER2 positive disease, usually again neoadjuvant therapy is preferred, chemotherapy combination with dual or single HER2 blockade. And then if the patient achieves the PCR, we complete the anti-HER2 therapy for 1 year. And if the patient doesn't achieve the PCR, then the indication suggests to go for TDM1. Next slide, please. So now, how the newer targeted treatments are changing the landscape of the HER2 negative early breast cancer management. So in hormone positive disease, we have the endocrine therapies. In HER2 positive, we have the anti-HER2 blockage, trastuzumab, pertuzumab, and TDM1. But in triple negative disease, HER2 negative disease, the options are limited beyond the chemotherapy. But while newer studies like Keynote 522, where pembrolizumab is added to the chemotherapy, reduce the risk of suffering from events by 37% as compared to placebo plus chemotherapy. The 3-year event-free survival is shows a benefit of around 8%. Overall survival benefit is yet to mature. IM Patient 031 study says that adding atezolizumab to the combination chemotherapy improves the PCR status regardless of PDL1, 57 versus 41%. Monarchy study shows the significance of adding adjuvant abemaciclib, which reduces the risk of invasive disease or death by 31%. Penelope and Pala study was an active study. Valvociclib did not improve the outcomes. CRATEX study was the addition of adjuvant capecitabine, which reduced the risk of disease recurrence by 30% and that of death by 41%. So with increasing evidence, BRCA mutated HER2 negative early breast cancer is also increasingly being recognized as a unique disease that can be targeted with PARP inhibitor treatment, which we will see in the coming slides. Next slide, please. So patients with BRCA mutated breast cancer is characterized by a more aggressive phenotype than sporadic disease. They are diagnosed at younger age. They are of higher grade. More patients present with CNS metastasis and more controlateral disease is found. Next slide, please. So this diagram slide shows the presence of BRCA mutation in different breast cancer types. Like we can see, they are common in triple negative disease, hormone positive HER2 negative disease. They are very rare. Hormone negative HER2 positive disease again not present. Hormone positive triple positive disease again rare. So the most common type is triple negative breast cancer type, as can be seen in the top line. So breast cancer mutations are more prevalent in triple negative breast cancer. Next slide, please. So these are the studies showing genetic mutations prevalence in Indian patients. So data suggests that 50 to 80% of individuals at risk of having a hereditary breast cancer are never tested as they do not meet the current criteria. So the current criteria needs to be modified with the advanced results research we are getting, so that more and more patients with BRCA mutation patients can be identified. Next slide, please. So now coming to the early breast cancer setting, upfront knowledge of BRCA status may inform decisions around surgery and targeted treatment. How testing for BRCA mutation at the time of diagnosis helps. Basically, at two decision-making points. First, when the decision about the surgery type of surgeries needs to be done. So MRM versus breast conservation surgery, as if we know the status at that time of the BRCA mutation, if it is positive, more patients go for MRM and even contralateral prophylactic mastectomy. And second, at the time of adjuvant treatment, if the BRCA status is positive, then according to the current criteria, if it is in the high risk, we can go for 1 year adjuvant olaparib treatment. So they have a more aggressive phenotype, higher risk of recurrence, and preoperative genetic testing impacts the surgical decision making also, in addition to the adjuvant treatment. Next slide, please. So preoperative genetic testing impacts the surgical decision. We have already seen that if we know beforehand the BRCA mutation status, around 76% of patients also goes for contralateral prophylactic mastectomy compared to 14% otherwise. Next slide, please. Coming to the Olympia trial, which led to the approval of olaparib, it was a phase 3 study of olaparib versus placebo as adjuvant treatment for high risk germline BRCA mutated HER2 negative breast cancer. So the patient should have a germline pathogenic BRCA1 or BRCA2 mutation. Somatic BRCA mutation patients were not considered in this, were not eligible for this trial. Patient should have a stage 2 or stage 3 breast cancer. HER2 should be negative. Patient should have completed local treatment and 6 cycles of neoadjuvant or adjuvant chemotherapy containing anthracyclines or taxanes. So 4 high-risk patient populations or subgroups were there. If we go for a neoadjuvant group, it can be divided further into triple negative, where non-PCR achieving patients were taken, hormone positive groups, where non-PCR plus CPS and EG score more than 3 patients were taken. Now, the adjuvant group, again, triple negative breast cancer, patient having more than pathological T2 and 1 disease, or if the patient is hormone positive, more than 4 positive lymph node patients were taken. So they were randomized 1:1, olaparib 300 mg BD and placebo. The primary endpoint was interval disease-free survival, and secondary endpoints were distant disease-free survival, overall survival, health-related quality of life, and safety and tolerability. Next slide, please. So we have already seen the high-risk criteria according to the Olympia trial. The CPS plus EG score is mainly used in clinical trials. Here we can see how this score is calculated. It is based on clinical stage, pathological stage, receptor status of the estrogen receptor, and nuclear grade of the patient. It can vary from 0 to 6. More than 3 qualifies the criteria for high-risk score. Next slide, please. So higher CPS plus EG score correlates with earlier relapse than those with lower scores, as we can see in this graph. Next slide, please. So baseline characteristics were well balanced in both the groups, olaparib and placebo. Median age was 42 and 43 years. 99% of the patients were female. BRCA1 and BRCA2 patient mutation were there in 71 and 28% of the patients. Both premenopausal and postmenopausal patients were there. Bilateral breast cancer was present in around 4 to 5% of the patients. Next slide. Around 50% of the patients received neoadjuvant treatment and 50% adjuvant treatment. Neoadjuvant platinum-based chemotherapy was used in around 26% of the patients in both the groups. Majority of the patients were triple negative, around 81 to 82% of the patients. Around 18% of the patients were hormone positive in both the subgroups. Concurrent hormone therapy was given in hormone positive patients in around 86 to 90% of the patients. Next slide, please. So, primary endpoint, which was interval disease-free survival, invasive disease-free survival in the intention to treat population. Here we can see hazard ratio of 0.58, 3-year IDFS rate, olaparib 85.9% compared to 77.1%, showing the significant benefit of 8.8% in the olaparib group. The curves started separating in the initial months only. At the end of 12 months, it was 93 versus 88, around 5% benefit. But the olaparib subgroup continued to drive benefit till the results are available for 3 to 4 years. Next slide. So the extended 4-year IDFS rate 82.7 versus 75.4%. Again, a benefit of around 7% persisted even at the end of 4 years. Next slide. Coming to the distant disease-free survival, around 7% more patients were free of distant recurrence at 4 years. Similarly, as we have seen in the previous slides, the curve started separating initially. Around 4% benefit was there at the end of 1 year, but the benefit persisted in the olaparib group at the end of 4 years, for which the data is available. Next slide. Coming to the overall survival, which is usually considered the gold standard in oncological trials. So olaparib demonstrated a significant OS benefit with 90% of patients alive at 4 years. 89.8 versus 86.4%, showing a difference of 3.4% at the end of 4 years. Hazard ratio is 0.68, which is significant. Next slide. So coming to the distant recurrence, around 2.6% patients experience CNS recurrence in olaparib group compared to 4.2 in the placebo group. If we see the second primary non-breast malignancies like ovarian, peritoneal, or fallopian, 9 patients in the olaparib subgroup had a second primary non-breast, and 13 patients in the placebo group. If we see the ovarian, only 1 patient experienced the ovarian malignancy, while 6 patients experienced ovarian malignancy in placebo subgroup, showing olaparib may have a benefit on the second malignancy or second primary malignancy also. Next slide, please. So coming to the subgroup analysis, consistent benefit was seen across all the subgroups. If we see by the neoadjuvant versus adjuvant setting, in both the benefit was there prior platinum use, TNBC versus hormone positive, BRCA1 or BRCA2 mutations. All subgroups derived benefit, as we can see in this graph. Next slide, please. Coming to the overall survival benefit across all the subgroups, again, adjuvant versus neoadjuvant or by the platinum use, by the receptor status, benefit was there. In the prior platinum use, if platinum was prior used, the confidence intervals are in crossing the midline, but still, if we see the benefit is there, p-value is significant. Next slide. More than 70% of patients completed treatment according to protocol without the need for a dose reduction. So the patient tolerated the olaparib well. Around 70% completed the treatment as per protocol. No dose reduction was needed in 75% of the olaparib group patients. Around 18% needed 1 dose reduction and 6% needed 2 dose reductions. Around the reason for reduction, the main reason for reduction was adverse event. Next slide, please. So around 10% of patients had to discontinue the treatment due to the adverse event. Reason for treatment discontinuation, mainly adverse event, or in 9% of the patient decision. The most common treatment emergent adverse event that led to discontinuation of olaparib are well known: nausea and anemia, basically. Next slide. So any grade adverse event in 90% of the patient, but serious adverse events were only in the 8% of the olaparib group. MDS or AML was seen in 2 patients of olaparib group, but 3 patients of placebo group also. Grade 3 adverse events occurred in around 24.5% of the patients, and adverse event leading to permanent discontinuation of treatment 10%, and 1 patient experienced death in the olaparib group compared to 2 patients in the placebo group. Next slide, please. So adverse events observed were consistent with other trials of olaparib: nausea, vomiting, anemia, fatigue, and in few patients, neutropenia, leukopenia, dizziness, and arthralgias. which were mostly grade 1, grade 2. Anemia was the only grade 3 adverse event occurring in more than 5% of patients. Next slide. So to manage anemia, blood transfusions were infrequently required. Most of the patients were managed with one blood transfusion only. Only 13 patients, which were 1.4% of the subgroup, needed 2 blood transfusions, and 3 patients needed 3 blood transfusions. Next slide. So 1 year of adjuvant olaparib maintained global health related quality of life, as we can see in the graph. In both in the neoadjuvant group and in the adjuvant group, quality of life was maintained with the use of olaparib compared to placebo. Next slide, please. No clinically meaningful change in fatigue severity occurred during the duration of the study in both the neoadjuvant and adjuvant group, as we can see in the graph. Next slide. There was no clinically meaningful change in diarrhea related quality of life between olaparib and placebo group. Nausea, vomiting comparison and diarrhea comparison we can see. So the quality of life was maintained as compared to the placebo group. Next slide. There were no clinically meaningful differences between olaparib and placebo for physical or emotional functioning subscale over time. Next slide. So if we see in nutshell, the targeted treatments in early breast cancer has improved event or disease-free survival, but overall survival improvement has been documented only by 2 or 3 drugs. If we see the trials, abemaciclib, palbociclib, they have shown the benefit of event-free survival, but overall survival benefit is still not there. Only trastuzumab in the HER2-positive disease has an overall survival benefit, and now olaparib with this Olympia trial has shown the overall survival benefit of around 3.4% at 4 years. Other drugs like TDM1, pertuzumab, pembrolizumab, and all addition of platinums in the triple negative breast cancer, they have the PCR or EFS data or DFS data, but overall survival data is only for trastuzumab and olaparib in the targeted groups. Next. So coming to the treatment algorithm for HER2 negative early breast cancer patient, first we have to see it is a triple negative or hormone positive. In triple negative, whether it BRCA mutated or BRCA wild type. In BRCA mutated, adjuvant olaparib for 1 year in high risk patients. In the BRCA wild type, we can have adjuvant pembrolizumab if pembro was used in the neoadjuvant setting, and we can consider adjuvant capecitabine for 6 to 8 cycles if the PCR is not achieved. In the hormone positive BRCA mutated patients, adjuvant olaparib for 1 year plus endocrine therapy. In the BRCA wild type, adjuvant abemaciclib for 2 years plus endocrine therapy. Next slide, please. So to conclude, the Olympia trial is the first to report the clinical benefits of a PARP inhibitor, that is olaparib, as an adjuvant treatment in patients with BRCA mutated, HER2 negative, high risk early breast cancer. Around 9% more patients were recurrence free at 3 years. 1 year adjuvant olaparib significantly reduced the risk of recurrence or death by 42% compared to placebo. Adjuvant olaparib resulted in patients living longer with 32% reduction in risk of death. 3.4% more patients treated with olaparib were alive at 4 years versus placebo. Consistent with previous studies, the safety profile of olaparib was limited and manageable. Most of the adverse events were grade 1 or 2. Test for BRCA mutation at diagnosis to inform treatment decisions and maximize long-term outcomes. Thank you for your patience hearing.
Well, thank you, Mukesh. Again, a very nice presentation about the data on the adjuvant or early breast cancer usage of olaparib. Now we have heard the data in both the scenarios, ovary and breast cancer. Now, what is the real world usage? So, to elaborate on that, I would like to invite Dr. Chitresh Agrawal, who is a consultant, senior consultant medical oncologist at Paras Hospital, Panchkula. Over to you, Chitresh.
Thank you, sir. Good evening. I would
Good
request you to please upload the slides from your end. So should I start? So the safety and tolerability of olaparib in Indian patients with ovarian cancer. This is the prospective single-arm phase 4 solid trial, and with this will see the real world, the usage, the advantages and disadvantages of olaparib. Next slide, please. So olaparib, as we have seen, is approved as maintenance therapy in patients with platinum-sensitive relapsed ovarian cancer. And currently, there is sparse information which is available on the safety of maintenance olaparib in our own set of patients, that is Indian patients. Next slide. So this is a prospective single-arm multi-center phase 4 study where eligible patients with platinum-sensitive relapsed ovarian cancer in complete response or partial response to preceding platinum-based chemotherapy regimens, they were given olaparib with the usage of 300 milligrams BD for 182 days or until its discontinuation. And the key endpoint of this study was adverse events, serious adverse events, and the number of deaths. Next slide. So between May 2020 and March 2022, there were 142 patients which were included in this. The median age of the patients were 52 years, with their age range being as low as 33 to as high as 73 years. The mean BMI was 26.1 kilograms per meter square, PS of 0, and 122 received 2 previous cancer therapies. Of 63 patients with known BRCA mutations, BRCA1 was found in 39, that is 60% of the patients. So complete responders plus partial responders plus stable disease at 24 weeks was seen in 53% of the patients, that is 73 in number. And grade 3 plus related treatment emergent adverse events were seen in 51 patients, which constituted around 37.5% of the study population. Next slide, please. So this is the safety of olaparib that was seen. So dose reductions were common, and the percentage of dose reductions were 41.2% in general. It was reduced to 250 milligrams in 39.7% of the patients and to 200 milligrams in 12.5% of the patients. Now, around 8.8% of the patients had to discontinue this drug, and the percentage of grade 3, adverse events was seen in close to 50% of the patients in this study. Next slide, please. So to conclude, SOLI study confirms the safety profile of olaparib in Indian patients with platinum-sensitive relapsed ovarian cancer. It is well tolerated, though it has some side effects. Some percent of patients will actually not be able to take this drug, but there were no new safety concerns noted in Indian patients also. Thank you.
Well, I think this was one of experience in the form of a data about olaparib usage, and each one of us is having a lot of other experiences. So let's now go on to a case-based discussion on breast cancer. And to move forward, I would like to invite Dr. Mir Hussain from SKIMS Srinagar, who will be the moderator. Dr. Mir, you're there, no?
Yes, sir.
Yeah, Dr. Mir was the first guy to be present. And should I invite your panelists or?
Yes, yes. Yeah, no,
Ah,
sir, you call them.
okay. So the panelists are Dr. Nitish Garg
Hello, sir.
hi Nitish, from AOI, Dr. Jitendra Arora from Patel Hospital, medical oncologist from Patel Hospital. Dr. Jitendra, are you there?
Yes, sir, I'm here. Good evening.
Good evening, ji. Good evening. And Dr. Moveen Mittal from Amar Hospital, Patiala. Dr. Moveen, are you there?
Yes, sir.
So I would like all my panelists to please switch on their cameras and let it be a good, lively discussion. Rest of us can join in and pull in. And Dr. Mir, you are open to throw question at the forum. Yeah, go ahead.
Your mic was in on mute.
Yeah. Yeah. Good evening. Thank you, Dr. Jiten, for introducing, and welcome to my co-panelists, and my sincere thanks to AstraZeneca for giving this opportunity. It was very nice to hear the initial two presentations on PARP inhibitors. So it will be not a question answer session. We will try to learn from each other, and this will be open to all the participants. But the comments should be very brief because we have a limited time span of 20 minutes. So I will have some hypothetical case, and we will talk about the integrating precision medicine in the management of early breast cancer. We had a very good presentation on the PARP inhibitors in the early breast cancer. So we will build on that. So that in that presentation, towards the last, so it showed that the two drugs which have a very huge impact in the management of breast cancer. One was the trastuzumab, and second is now olaparib. So anybody recognizes who is this lady? So this is an open to everybody. She had some landmark contribution in the development of trastuzumab.
Herceptin. Yes.
Yeah, yeah. Can you
I'm
tell
not
you
sure
who is
about
she?
the name. Not sure about the name.
Oh, yeah.
I
Anybody
think
can
it
just
skipped
guess
my
who is
mind.
she? So this is, yeah. So she's Barbara Bradfield. There's a famous Hollywood documentary on her, The Living Proof. Her story is very interesting. She was diagnosed with breast cancer at the age of 51 in 1990. And whatever treatment at that time was available, she was given most of the chemotherapy drugs. Then one fine day, she was told that now there is nothing left. She had a progressive disease, and you go home, and you need some hospice and a palliative care. But something good was for her. So somewhere in 1992, Herceptin was discovered, and finally she was the one of the luckiest patients in that initial trial of 12 patients. So she was convinced very difficult with the difficulty by the principal investigator of the trial. But then the rest is the history. She lived for more than 30 years after the diagnosis of her metastatic breast cancer, and after she was enrolled in the trial for trastuzumab. I think she died in 21 at the age of 83. So we know that this Herceptin changed our understanding about the breast cancer. It is molecular pathogenesis. Now we have moved from the conventional pathological typing, and we're going more and more towards the molecular typing of the breast cancer, as we know that we now divide them, whether it is luminal A, B, basal, to positive. So this was a landmark discovery. This was the guy who was behind it, and he did a tireless work. So anybody knows this gentleman? Again, very closely associated with Barbara Bradfield. He was one of the famous medical oncologists working in the University of California, Los Angeles. He was intriguing with that some of the patients with the breast cancer, they had a very difficult course. They don't respond to any of the conventional chemotherapy. This was always in his mind that what the subset of patients had, and GreenTech was a company which was basically manufacturing the bovine insulin. He had 2 3 immunologists there, and he used to convince them that please look what is there in this subset of patients. So somehow they found that they have a very aggressive expression of a factor which promotes the growth and proliferation, invasiveness, and they finally discovered this was a HER2 and given it a name. And then he convinced them that if you can produce some magic blood against this, and with difficulty, they agreed. And this was the landmark discovery. And he was one of the pioneers in that trial. And this was then approved. This was given basically a very rapid approval by the FDA way back in 1998. He's Dennis Solomon. He is credited with the discovery of trastuzumab along with the two immunologists. And one good thing was that Green Tech was initially not ready to invest in oncology. They were telling that most of the patients, they may die and we will not get anything. Patients will not afford the treatment. It will be costly. But then what is they launched the trastuzumab, they basically shifted from insulin. They closed that chapter and solely shifted towards oncology. So let us move towards this is a hypothetical case. This is basically a background about the breast cancer, how these targeted drugs have come in the management of the breast cancer. So we will have this hypothetical case. This is provided by the AstraZeneca. I have some modification which I did in the initial 2-3 slides. So we had a 52 years old female. She was postmenopausal. She had no comorbidity, fit. She had presented with a lump in her right breast. This was around 5 centimeters. It was along with she had a fixed axillary lymphadenopathy, and this was clinically T3 and 2. And her staging workup was done with CCT, chest, abdomen, pelvis, and bone scan. They were all negative for any metastatic disease. And was, hormone receptor positive, HER2 was negative. So this will be a general comment. Do we need to do any additional testing in this stage of breast cancer with this molecular profile?
I don't think so, sir.
Yes.
I think she has been evaluated sufficiently and staging investigations have been done. Only thing is we can just get her routine investigations along with some cardiac mark evaluation to start her on chemotherapy initially. So I would like to just go ahead with a neoadjuvant therapy.
Yes. So we don't want to do any PET scan, nothing.
So CT has been done, sir. CT
Yeah.
is fairly well. So CT, chest, abdomen, along with the bone scan, I'm happy with that.
Yeah, so that is a good thing because many of the patients in our clinic will come that even in early stage, they will come with a PET CT, which will add to the confusion. So any more comments? Dr. Moveen, Dr. Jiten?
You can discuss with the surgeon and put the clip over the tumor
Okay.
size so that in the future they can go for the breast cancer surgery after neoadjuvant chemotherapy.
Okay, yeah, thank you. So should all we are discussing PARP inhibitors, so we will go towards that. Should all breast cancer patients be tested for this germline BRCA mutation? Dr. Moveen?
Sir, depending on the criteria, incision criteria, which is to be followed for advising a patient for the BRCA testing, if the patient age is less than 45-year-old and if there is any history of any prostatic, pancreatic, or ovarian cancer, and there is family history of or any of the relative having the breast cancer, one relative or more than 3 relatives having the history of the breast cancer, prostatic cancer, or ovarian cancer, or male breast cancer, they are the indication for doing the BRCA testing in a patient.
Yeah, so we have the guidelines, consensus guidelines from NCCN and ESMO. So what you are already telling that these are some important consideration where we do the germline BRCA mutation in the breast cancer. So you have already enumerated and rest are here. So we have the various indications, and if patient fits in, we should do this as a part of basic workup in such set of patients. So does it have any impact on the treatment in the early if we want to go for surgery or neoadjuvant treatment?
Yes,
Dr. Nitesh?
definitely. Yeah, definitely. If the patient turn out to be positive for the BRCA in early breast cancer, and if patient turn out to be positive for BRCA, then prophylactic mastectomy and the bilateral mastectomy can be done. And along with that, if the patient is BRCA positive, also salpingo-oophorectomy can also be done in prophylactic cases if the patient is positive for BRCA.
So Dr. Nitesh, you have any
I think, sir, patients won't be agree for prophylactic because the body image issues, and definitely we tell them, but in my last 6 7 years, I had only one patient who was willing to get it done, not more than that. So the evaluation changes, and there was some data that if we do breast conservation surgery, adding radiation may add some benefit. Deteriorate some condition or increases the chances of reoccurrences if the patients are BRCA mutated. But as of now, the recent update says that it does not change. So post-surgery, definitely radiation. And yes, prophylactic surgeries can be explained and if willing, can be offered.
Yeah, so as Dr. Mukesh has extensively talked about this, that it may have a bearing that we may upfront think that we may have to go for MRM if we're contemplating BCS, because if it is a germline BRCA mutated, so we have to give the option to the patient that BCS is not a option. We have to go for mastectomy in the diseased breast, and even if she agrees, then we may give the option of contralateral prophylactic mastectomy, what Dr. Moveen is telling, and what we agree with. If patient is already treated, then they will not agree. Most of our patients, because of cultural and our educational and other social factors. So this is especially for the Western population, which are very well concerned about their health issues and then the long-term outcomes of these, and was basically fantasized by the what is her name? That actress, very famous.
Angelina Jolie.
Yeah,
Jolie.
Angelina Jolie. Yeah, she fantasized this very, because there was a lot of media hype with her mastectomy. So if we know at upfront, we may give them the option of that you have to end up with the mastectomy rather than with the BCS. So these are the results of studies which showed that those who were upfront known, they were offered the mastectomy compared to the BCS. So then there are challenges in our setup because of labs available and then interpretation of the results. And then I think there may be differences between us and the West about what are the pathogenic or likely pathogenic variants, because we don't have any the data pool in our setup of population. So Dr. Nitesh may give more comments. The challenges we face in performing the
Challenges
BRCA.
is first of all convincing a patient, genetic testing, then they will be scared. It will be some social stigmas associated to that. After that, the testing, we don't know, is it as equivalent to the Western data that we get? Then the variance of unknown significance we get, it is not being updated in our database. So that is a issue which happens. So that updation has to happen every 6 monthly. Otherwise, we don't know how many patients of ours from variants, VUS variants of unknown significance changes to pathogenic variants. So that updation never happens in India. I think it has to happen at some point of time. So these are the usual challenges.
Yeah. So Dr. Moveen, you have any comments?
Yeah, definitely, sir. It's a in a country like India, when patient turn out to be BRCA positive, it's very difficult to convince patient for mastectomy or bilateral mastectomy or any prophylactic surgery. Uh, that also because of the social stigma and because of patient hindrance undergoing prophylactic surgery.
Dr. Jiten is, I think,
Yeah,
is he
can
here, sir?
I just want to ask one question. Uh, all of us are sending BRCA mutation testing. So, by what technique are you sending BRCA mutation testing in each and every patient?
At my center, sir, it is done by NGS.
Okay.
Sir, we are also performing the NGS, but we are doing with the company associated coupons because it will be a benefit for the patient at around cost of 6,100 to the patient. So we are generally performing BRCA and BRCA2, and sometimes we are doing the hereditary cancer panel test by NGS.
So nobody is doing reflex MLPA.
So if it's a strong suspicious history, then we are sending separately MLP also.
Okay, so routinely you're not sending reflex MLP, you're doing only NGS.
Only, yes, sir.
Okay, so okay, so I mean, how many of you are sending MLPA as and when required, and how many of you are sending MLPA routinely? Or you're not sending MLPA at all?
I have not done so.
So anyways, the point what I'm wanting to raise is that yes, we may miss a major chunk if we don't send a MLPA. So NGS alone won't suffice. So that is just the point I want to make. Dr. Mir, you can go
Yeah,
ahead.
sir, yes. So besides labs, we have issues that if somebody turns a female or his family, they are aware that somebody is BRCA positive. So then most of the centers we don't have the qualified geneticists, counselors who will then go their family screening. So these are some important issues besides doing from the labs we have available. But then these are the issues that if somebody has a BRCA, then they have a whole family is at the risk of developing, going under this genetic screening, and then what after that? So these are some important issues, not only ordering the test, and then there are after test problems which we face. Most of the centers we don't have geneticists, we don't have counselors. It is usually going out, it is outsourced, and then the issues come up. It has, I think, it may have some medical legal issues as well. So this was elaborated by Dr. Mukesh that if we order this in upfront setting, that we may in the set up patient which has a strong indication, so we may have a say on the surgical management as well as in the adjuvant setting. We give the olaparib as a maintenance therapy. So is there any importance of testing? Though we always do germline testing in breast cancer, is there any role for somatic BRCA mutation in breast cancer? So Dr. Nitesh.
I think as of now, not in the upfront setting, sir, for adjuvant treatment. Maybe probably once the patient has a metastasis, then the role of somatic testing comes in place. And after, of course, after exhausting all our options of treatment. So then
So
there, I
Dr.
think there is a role of somatic BRCA testing. Otherwise, I'm not very convinced on doing somatic BRCA.
So Dr. Kanika is here. So what is the difference that we do in breast? We can treat them either on germline or on somatic, but the same is not true for breast. If you have any, because you have presented this extensively, this breast ovarian cancer. Yes,
Don't know the difference. Why? Because the data is not there in the breast regarding the somatic testing. Because in the ovarian, even we have the HRD positive subset also. Whether that subset is associated with the pathogenesis in breast also, that we still don't know. So doing an extended panel may not be very visible, because then we don't know what to do with those test results actually.
another thing is that if we have a germline negative, even in ovarian malignancies, they may have a somatic BRCA 1 or 2 mutation, and in that setting, same is not true for breast cancer. Maybe we don't know many things.
Just want to put in a word that this point was discussed in other forums also.
Okay.
And it was found that the trials that were conducted in breast cancer, they didn't take somatic BRCA mutant breast cancer. Though it's not that they won't be effective, because in metastatic setting, as Nitesh also said, yes, there are some anecdotal reports that in somatic BRCA mutated breast cancer, and maybe in future you may have somatic BRCA mutant breast cancer being treated with olaparib.
Like the way it has started in prostate, sir, HRR has been started. We have started doing HRR. So here also, I believe there is a importance of HRR, maybe in a form of somatic BRCA for breast. But as of now, most likely it is indicated in metastatic cases once most of the options are exhausted. Otherwise, surely the test, as you said, the tests have the trials have not included. Other thing, maybe the pathogenesis or the natural history of the disease of ovarian cancer is different from the BRC, this breast cancer. So it is a surface disease. So maybe it is the nature of the disease that we tend to add on these drugs once we found out these are HRD positive.
Yes, but Dr. Nitish, we agree with you that there is not much role except the metastatic setting where exhausted most of the lines. There is some data, phase 2 study, especially they have done both germline PALB as well as somatic BRCA1. And they have shown that there is some almost 50% overall response rate is in this subset of population, but this is just in the developing phase. Maybe in the future we will get it and it will come in the management of that subset of patients. So, what factors do you consider once you identify an early breast cancer with a high risk of recurrence? So, Dr. Mukesh has elaborated, and we will add on some more factors. If we have the first is the tumor stage, so we know that higher the stage of the tumor, there is more chances of the recurrence than the nodal burden. If it is higher nodal burden, more chances of recurrence. Then failure to achieve PACR. This is one of the important considerations once we give the neoadjuvant chemotherapy, because no neoadjuvant chemotherapy has till that converted into the OS advantage. It has its own advantages and few disadvantages, but failure PCR is a surrogate marker. Maybe in the future we may get that those who achieve the PCR, they may have a long-term survival rates. But as of now, we don't know that. Maybe it is in the coming years we will come to know that this definitely translates into the overall survival. But as of now, we say that the PCR, which may be a surrogate marker. So those who achieve PCR, they usually do good. And if there is a failure to achieve the PCR after the neoadjuvant chemotherapy, especially those who are TNBC or HER2 negative or even hormone receptor positive, they again have the high risk of recurrence. And then the high CPS and EG score, so it includes the clinical pathological staging, then estrogen receptor and the grade of the tumor. Higher the score, there are more chances of the long-term recurrences. And then the molecular testing, especially we know that the oncotype DX recurrence score, this is usually done in the adjuvant setting in the post-op state. So these are the various trials which have shown that these risk factors, we know the Olympia, Monarch, Penelope, Keynote, I'm Passion trial. By and large, they have looked at these factors, especially the non-achievement of PCR, high-grade tumors, higher nodal burden, high Ki67, and higher nodal stat, and non-achievement of the PCR after the neoadjuvant chemotherapy. So the CPS, there are online, there are scoring systems. This is used in clinical trials for especially assigning the high risk of recurrence, and we may integrate in the clinical practice. So those patients who have the high this score, their outcomes are not good as compared to the patients who have the these lower scores. If we see the DFS in a meta-analysis of 8 trials where those patients who have a higher score, their long-term outcomes were not good. And this is how we calculate this CPS EG score. We take the clinical stage, pathological stage, hormone receptor status, grade of the tumor, and then look at the 5-year distant metastasis-free survival, disease-specific survival, and then the distant metastasis-free survival. So benefits of neoadjuvant chemotherapy, we're well aware that it helps us in downgrading the disease, especially getting us the idea about the biology of the disease, then feasibility of doing BCS in a set of patients. So this patient was given neoadjuvant chemotherapy with 4-AC, 4-paclitaxel, which is the standard protocol, and there was some downgrading from 3A, it came to 2B, but there was no PCR. but there were no nodes.
Sir, sorry for interrupt. Please conclude your talk.
Yeah. So she was at this stage, she was found to be germline BRCA positive and KI was 20%. So would you prefer to give her adjuvant therapy, and what would be the adjuvant regimen? She has received full neoadjuvant chemotherapy. Dr. Nitish?
Is hormone positive, right?
Yeah, she's ERPR positive, HER2 negative. And she was germline BRCA positive.
I think I would like to add ribociclib.
Yeah. So
along with the AIs.
Yeah. So she was given radiation, and after that she was started on olaparib. These are the trials which have shown that those patients who are ER positive and HER2 negative, if they are germline positive, so we add olaparib. There's a category 1 indication for this, continue for 1 year, and if they are germline negative, we give abemaciclib as per the Monarch E trial for 2 to 3 years. So these are the benefits. Dr. Mukesh has already discussed it, that it all favors that olaparib 1 year in the germline BRCA mutated breast cancers. They are HER negative, and this is the conflicting invasive disease-free survival results with the CDK4/6 inhibitors in the adjuvant maintenance setting. Except Monarch, none of the trials has shown any advantage. So then the Ki-67, we know that it helps us. It has just a prognostic significance. It will not dictate us the what treatment we give. So these are the results of the Monarch trial, where it shows that those who are ERPR positive and a subset of patients who are high risk, more than 4 nodes or more than 5 centimeter high grade, more Ki-67, they benefit with the maintenance abemaciclib along with the endocrine therapy. So if the patient is receiving anastrozole, we can continue with the PARP inhibitors. There is no much worry, so they can take it safely. And then the role of platinum, there's a conflicting that those who are BRCA positive, BRCA mutated, some people were initially propagating that they should be treated with the platinum with the taxane, but most of the trials did not show any advantage, except 2 trials which showed that they may have some improvement in achieving the more PATH-CR rates. And if this patient had TNBC, so this is what we know. Keynote trial has come that pembrolizumab neoadjuvant setting along with the chemotherapy, and then giving the adjuvant setting for 9 more cycles. It has definitely added to the EFS as well as more PATH-CR rates that may convert into the long-term better survival. And then adjuvant immuno, we know from the same trial, we can continue it. And this is the data from the Keynote 522 trial. We showed that there is a benefit with the neoadjuvant pembro followed by the adjuvant pembro. And these are the NCCN guidelines. This has come that those who are hormone receptor positive, HER negative, if it is early breast cancer, and adjuvant endocrine therapy along with the olaparib in the BRCA1, 2 mutated, and those who have CPS EG of more than 3. And if it is triple negative, again, we can give, if they were given pembro in the neoadjuvant, we can continue it. If they were not germline mutated, we can give adjuvant capecitabine if they have a residual disease. And if they have a residual disease after the neoadjuvant chemotherapy, germline BRCA1 or 2 mutated, we can give them olaparib for 1 year. So thank you.
Oh, thank you, Dr. Mir. Well, there are actually 2 major issues about the use of adjuvant olaparib, especially in the context of usage of IO in the neoadjuvant setting, and also in hormone receptor positive, whether to use Avima and versus IO. So there can be a lot of discussion on both these subjects, because we all are not yet clear that because olaparib cannot be safely continued with pembrolizumab, and also I don't know whether how to give or sequence Abema and olaparib. So so we can carry on this discussion later on, but I think we are getting late for a very interesting another case discussion on ovarian cancer. And we are very clear about the BRCA mutation, germline and somatic, but what about HRD? So more and more people are now sending HRD, courtesy availability of coupons. I would like to invite Dr. Devinder Paul, who is the senior consultant, Fortis Hospital, Ludhiana. He'll be taking us through to how to integrate HRD in the maintenance part in ovarian cancer. Welcome, Devinder, and would you like me to invite your panelist?
Yes, sir. I think only two are there. I think Dr. Imran and Dr. Arun are there. I think Dr. Pravesh and Dr. Keshav are there, or they are not there.
I don't know.
I don't see them actually, sir.
Panelists, please
Sir,
switch
Dr.
on.
Keshav and Dr. is not available.
So that's okay. I think Dr. Kanika is there. Dr. Nitish is also there, I think.
I think we all are here for the discussion.
Yeah,
You can throw questions at any one of us. So,
sure.
Yeah. So, shoot.
Right, sir. Good evening. Thank you, sir, for inviting me for this panel discussion. PARP inhibitors we are all discussing for the last 1.5 hours. They are really important drugs as far as ovarian and breast cancer are concerned. We all know the data about the somatic and the germinal BRCA mutation, but the area is expanding nowadays, and we are talking about HRD more as compared to BRCA nowadays. Next slide. So I'll start with a case: a 59-year-old female with abdominal distension, CA125 raise, ECOG PS1, no relevant personal history. Next. So high-grade serous ovarian cancer, FIGO stage 3C with extrapelvic and peritoneal metastasis. Next slide. So would you consider genomic testing for this patient upfront, or you will wait for some time? So I'll just start with Dr. Arun, if he is available.
Yeah, I'm available, sir. So any advanced stage ovarian cancer, I like to do the genomic testing after proper counseling. And my usual practice is to do genomic testing based on the family history and based on the educational status of the patient.
Same question to Dr. Keshav also. Would you like to do all the genomic testing, including the HRD upfront, or you will wait for the HRD later on, or you will just go for the genomic germline BRCA testing upfront? If he's not there, to any of the panelists whosoever is available, any difference of thought that you go for only germline testing upfront, or you go for all the things, including the HRD? Anybody?
Dr. Devinder, good evening.
Yeah.
I think, if we do germline BRCA1, if it is negative, we have to do the full panel.
So I agree with you. It's some sort of a reflex. If the germline is negative, then we go for the HRD testing. Yes, absolutely. Next slide. So same thing, the genomic testing approach would you follow in this patient? Next slide. So again, the same thing, but it will benefit to do tumor HRD test upfront, given the data which we have from the pivotal ovarian cancer trial, including the POLA one and the SOLO one. So should HRD testing upfront, especially in a patient who is germline BRCA negative, should be done in all the patients of stage 3, 3 or 4 ovarian cancer or not? Anybody? Dr. Hussain, Dr. Arun, whosoever is available.
Yeah, HRD is it's mandatory. So the thing to go forward is you have to educate the patient. You have to convince them to do the HRD testing because it will inform to have a proper the maintenance strategy. It will decode the maintenance strategy. So I like to discuss with the patient. It's the patient call to think about it. So anyway, both the germline and tumor BRCA, I'll discuss with the patient, whichever comfortable based on the cost effectiveness. I will consider doing both of the tests upfront also.
Sure. And in this thing, I'll just say that what Dr. Jatin was saying, that whether we are doing MLP or not, I think MLPA should be done. I agree with Dr. Jatin, because that is a few, I think around 3 to 5% patients, they can be missed in the germline, and we have to do MLPA, and I am doing it routinely nowadays. Next slide. So this is the graph showing. So if you do only the germline testing, only around 15% patient can be incorporated. But if we do the tumor also, it goes up to 20 to 30%. But nowadays, if we do the HRD, then almost half of the patients of all the ovarian cancer stage 3, 4 are almost found to be HRD high, HRD positive, and they can avail some benefit, not some, quite a benefit from the PARP inhibitors. Next slide. So this is the ESMO guideline recommendation for HRD testing. You can see for the germline BRCA, it is the level of evidence of 1. Even for the somatic also, it's level 1. Or coming to HRD, there are 2 types: genomic stability score and the loss of heterozygosity, and both are also recommended nowadays. Next slide. So which test would you prescribe to detect homologous recombination deficient HRD in newly diagnosed advanced ovarian cancer patients? So what I mean to ask is that nowadays we have multiple companies, multiple labs doing HRD analysis, and there are 2 types of tests which are available. There are HRD and the HRR. So in our practice, which you prefer, HRD or HRR? Anybody? Dr. Arun, Dr. Hussain?
Yes, sir. So I consider only HRD, but HRR I have never done in my practice. Even in HRD, that is a little bit of confusion of doing the test because our Indian testers are a little bit costly. So moreover, the turnover depends on the AstraZeneca coupon. I used to prefer both genome or strand. So I'm routinely prescribing for all the patients who are eligible, and it's a patient call to take the test on their own.
So I'll like to ask anybody who's doing HRR nowadays. Anybody? Nitish, Kanika, anybody? I think nobody is doing HRR nowadays because we have the availability of HRD. Although the still the HRD testing in our country is not that standardized, but still we are doing it and we are getting quite a good response also. Next slide.
Devinder, I just want to say that HRR in ovarian cancer was not actually studied in the trials. So I think it was just a matter of convenience or availability we were doing it. Otherwise, it is not the right test for ovarian
It's not the
cancer.
right test. It doesn't incorporate all the deficiency which we found in
So HRD is actually a phenotype we usually study.
Next slide.
Dr. Devinder?
Yeah.
So we do, I think, in prostate.
Yeah, we do in our
HRR.
prostate. We do in prostate. So this is the slide showing what is the difference between HRR and HRD. So HRR gene test, HRR is basically a set of genes which cause the HRR loss, and BRCA is one of these tests. Next slide. But if there is a HRR deficiency, the phenotype which the cell produces, that is the HRD. So it is the HRD incorporates all the HRR genes, and the HRR deficiency is one part of it. So there may be other factors like promoter methylation, undetermined causes, other genetic mutations. So these all lead to a phenotypic genetic aberration, which leads to genetic instability, and that is all incorporated in the HRD. So HR is the loss of cause of HRR loss, whereas the HRD looks for the effect of the HRR loss, and therefore HRD is the standard which we should all follow. Next slide. So I'll be skipping through the slides because of scarcity of time. So this is just on the left side, you can see the typical HRR report. On the right side, you can see HRD. HRD is primarily documented in the form of a score. And you can see the modal cutoff most of the time is 42. And depending on this report, we can either find the patient to be HRD high or HRD low. Next slide. So in the POLAR study also, if you see in the POLAR study, almost 19% were found to be HRD positive, excluding the somatic BRCA. So 19% patient had HRD high, and they were not having somatic BRCA mutation. And some exploratory gene panel analysis was also done in various trials, like the study 19, ADL3, and the ANOVA. They all found they had either the restricted panel or the 18 gene higher panel. So they all found that. Next slide. So among these, the extended panel, that is the study in the study 9, which 26 genes was incorporated. Next slide. You can see in all these expert panels, they couldn't find that much of a patient who had HRD positive as compared to the POLA 1 study. So furthermore, what we see is that in the patient who is mutant, HRR mutant, just the presence of HRR mutant doesn't give you the predictive PFS benefit as compared to the HRD positive. You can see there was no PFS benefit was seen with the OLA and BEV in the HRR mutant patient identified using the predefined panel of 13 genes. And similarly, there was no benefit for the arm was seen regardless of the panel used, whether we use the 13 gene panel, 23 panel, or the 5-gene restricted panel. So these further tells us that HRR mutation doesn't give you that PFS benefit. It is only the HRD positivity which gives you the benefit as far as these drugs are concerned. Next slide. So similarly, you can see even among the small non-BRCA HRR mutant population, HRD by genomic instability was predictive of PFS benefit with this arm of olaparib and bevacizumab, and not the HRR mutation. Next slide. So do you think a single biomarker measures the measure of HRD as sufficient to determine the genomic instability? Anybody? So what I am trying to ask is HRD the standard now? It can incorporate all the biomarker deficiencies of the HRD phenotype, or is this field still evolving?
Sir, regarding the HRD, I consider HRD as a single most test, but depends on the reporting only, because the GA score before it was 42, now they're reduced to 33. 33, so yeah. we may miss some patient also. So I consider both HRD and germline BRCA should be the standard. Yes.
Next slide. So genomic instability is assessed by looking at various aberrations. There are multiple things to be seen in this, like the loss of heterozygosity, loss of allelic imbalance, and large-scale state transition. Only the genomic instability scar is the only genomic scar assay that has been tested till date in the randomized trial. Other modalities of tests, they are not yet tested in the randomized trial. Only the GIS score has been tested in the phase 3 randomized trials. Next slide. So these are three tests which are available for the HRD scar test. The standard of care till date is the Myriad, My Choice CDX, and we are also doing it in foundation testing, and some Indian HRD testing is also available. They all differ in the variant type which can be detected and the GIS score markers which are taken into account. And you can see if we see the Myriad testing, it is quite a costly thing, more than $4,000. And the foundation is also very costly, $3,400. In India, the testing which we people in India are doing, that costs somewhere around $900. Next slide. You can see these are tests which are Indian companies are doing. They're primarily incorporating all the same algorithm as the Myriad testing is done. They take into account both the BRCA tumor BRCA mutation as well as the genomic instability scar. They use all the algorithm which is used in Myriad, and they come up with their own HRD reporting also. Next slide. We have to take into account all the things: loss of heterozygosity, other thing, allelic imbalance also, and the in-state aberrations also. They all have to be combined, and individually they are not important, but they have to take into all these aberrations have to be taken into account, and only once they are taken they are combined, then only the things comes up to be either positive or negative. If we take them as individually, they are not predictive of the response. Next slide. Next. So very important. According to you, what are the barriers for adopting HRD testing into our clinical practice routinely? Anybody?
Only the cost and tissues matter, sir.
Absolutely, no doubt about that. HRD is still a very, very costly drug, a costly modality to use, and it is very difficult to counsel a patient. First of all, in a setting, first of all, we have to see whether the patient can actually take the PARP inhibitors in the maintenance setting. If she is not able, if she doesn't have the financial capacity to take olaparib or rucaparib, then I don't think that doing HRD testing and spending around 30, 40, 60,000 is of any use. Next slide. So this is the Myriad classical HRD reporting. You can see they give all the scoring, whether it's HRD positive or negative, and they also give the status of the somatic BRCA also. Next slide. So multiple other tests have also been taken, and they have all shown to be correlated with the Myriad choice, and they have shown that there is a high rate of concordance between all these tests also. Next slide. So in the POLA1 trial, 18% patients with HRD tests were unknown. So how to mitigate this in real world? Very important thing. We should have the proper tissue blocks available, and they should not be preferably not more than 3 to 4 years old. And especially the specimen should ideally have more than 30% tumor to normal ratio. And unacceptable samples like brain metastasis, bone metastasis treated with acid decalcification or endometrial tissues, they are unacceptable for this testing. And the pathologist should review the case and select the most optimal sample. It is said that the omentum and lymph node tends to have suboptimal samples, and another block should be considered. and at least the tumor size of more than 25 square millimeters should be recommended. Next slide. So regarding this case, germline testing for BRCA came out to be negative. Next. Somatic also came out to be negative. Next. And this patient turned out to be HRD positive by the myriad testing. Next slide. So again, this patient received all the treatment, neoadjuvant chemotherapy, followed by interval debulking surgery, and followed by adjuvant paclitaxel and carboplatin. So what about the maintenance treatment? Next, anybody? What should be the ideal maintenance treatment for this patient? She has received paclitaxel, carboplatin, and she doesn't have received bevacizumab, and she has turned out to HRD positive. Anybody? Nitesh,
So
Kanika, Arun, Mrs. Anybody?
yeah, wild type HRD positive, the way forward without bevacizumab, the way forward will be the olaparib. That's the current standard of care.
Yeah.
So I will consider only olaparib in this
Yes.
patient.
So anybody who differs? Anybody? I don't think anybody can negate that. Next slide. So what are your considerations for including bevacizumab along with chemotherapy? Very controversial topic to have, whether to use upfront bevacizumab in a C ovary patient before in a neoadjuvant setting and the adjuvant setting. Anybody has their opinion regarding the use of bev as far as the PAOLA-1 study is concerned? So you routinely, my question would be, are you routinely using bevacizumab upfront in CA ovary or fallopian tube stage 3, stage 4?
Yes, sir. Yes, sir. I'm using, sir. I'm using only the 7.5 milligram of bevacizumab. So irrespective of the stage 3, stage 4 with ascites, without ascites, my regimen will be the same. Carbo, Pacli, and bevacizumab 7.5. So before surgery, before third cycle, I used to stop. Then after surgery, I will immediately restart. And based on the platinum sensitivity, I just integrate the olaparib if they are not willing for testing. If they are willing for testing, then it's well and good. So I have many options, 2 options, whether O plus B regime or only BIVA regime. So this is my practice over here.
Anybody who differs or who has a different way of going through?
If a patient is germline BRCA mutant, usually I don't start off with bevacizumab, at least for before surgery. If my patient is responding, most of the patient undergo interval debulking. So I use practically Bevacizumab only after surgery, and maybe from 5th cycle onward, 2 cycles along with Bev I give for chemotherapy, and then I continue practically. Though people say that you should start off with the 2nd cycle onward and all. For germline BRCA, you don't need to. And for stage 3, I usually avoid. Stage 4 onwards, Bevacizumab I do tend to use.
Yes, sir, I agree. It's a controversial topic. I agree with you in stage 4 when the interval debulking surgery is not going to give you that much of PFS benefit. I agree. We can. There is a notion that you can add Bev upfront, but I agree if the patient is stage 3 and given our context, because the data of Bev using in the PAOLA-1 trial, there are multiple things to be taken into consideration. Further, we all know that CA ovary is a thing to relapse quite a lot, and we all depend on the platinum sensitivity. Whether the upfront use of bevacizumab alters the platinum sensitivity or not, that is also a question. And I agree that in stage 4, if the patient is not going to avail much of a benefit from the intracytoid surgery, then Bev can be used. But as you all know, Bev has its own complications also, and its cost factor is always there in our setting. Yeah. So I agree with both the panelists. Next. So what would be your maintenance therapy approach for this patient? I think it's written wrong because the patient is HRD positive, and if she has received BEV in the chemotherapy arm, then the patient should receive the PARP combination along with BEV as maintenance. Next slide. So I'll just skip through these slides. This is just showing that the testing for genomic instability is recommended. It identifies a subgroup of women who are BRCA wild type, but they still derive greater benefit from the PARP inhibitors. Next slide. So we all know that giving PARP, it actually gives us the benefit of the PFS, the first PFS, the duration of what we call the treatment-free interval. It's prolonged a lot, as we also know the data from these studies. And we get a lot of PFS benefit if used in the first line, especially in the patient who are BRCA mutant or who are HRD positive. Next slide. So we can see in this study, the PFS benefits was observed in HRD positive and also in those patients who are non-somatic BRCA mutant ovarian cancer patients and who have received the first line platinum taxane chemotherapy plus BEV. So in all these patients, maintenance olaparib gave us a very, very good PFS benefit. Next slide. So even in this trial, both this additional subgroup analysis also demonstrated a very good activity as far as even the PFS2 benefit is concerned in the HRD positive patients, and not just PFS1, but even the PFS2 in these patients were quite significant. Next slide. So similarly, niraparib also has shown similar clinical benefit in HRD subgroup, and it has also shown a very good PFS benefit as compared as we have seen in the olaparib also. Next slide. So would you maintain this approach differ if there was no residual disease after the surgery? Anybody? Because what I'm trying to ask is, if there is a residual disease post surgery, would you consider changing your maintenance approach irrespective of the HRD or the BRCA status, or would you still go with the guidelines only? What I'm trying to ask is, if the patient is BRCA negative, HRD negative, and she has not achieved that much of a response in the neoadjuvant setting, and that there is still quite a bit of disease present in the post-surgical specimen, would you still go ahead with the same chemotherapy approach and follow that with the same maintenance approach, or would you like to consider adding PARP inhibitors in this setting? Anybody?
So my maintenance strategy will be, once they are both wild type and HRD negative. So if there's a platinum CR or PR, if the patient, I will tell the informed decision of the patient to take a olaparib for a fixed duration. So another scenario will be, if there is still a residual disease left behind, so maybe I consider bevacizumab with olaparib as a maintenance strategy also. But otherwise changing the chemotherapy, I think in this case I won't do that.
I agree, Dr. Me too. If the patient has not seen that much of a response in the neoadjuvant setting, then in the adjuvant setting, I will consider adding BEV, and maybe depending on the patient's history or the family history or some other things, I might consider going for the PARP also. Next slide. So as I told you, there was a substantial PFS and PFS2 benefit in the HRD positive patient, regardless of the clinical status in the FOLA1 study. Next slide. So if the patient is a somatic tumor BRCA mutant positive, what would be a preferred maintenance option? Anybody somatic BRCA positive patient?
Somatic BRCA positive means just straight away PARP, olaparib, that's it.
Yeah.
So I never consider bevacizumab.
Anybody who differs?
So I would say that if you see the data of olaparib, then germline BRCA has the best data.
Yes.
Somatic BRCA is not having, if you see that subset of the thing, you may add Bevacizumab if possible in a somatic BRCA. Because alone I don't think that will lead to that much of benefit. Otherwise, yes, single agent olaparib will also do.
I agree, sir. If we have used upfront BEV, then we can combine BEV with PARP. But I agree the penetration of these drugs in the somatic BRCA is not that great as compared to the germline BRCA. Next slide. So this is the summary of the approved maintenance studies in the first line. You can see we have the data from the SOLO-1, PALA-1, and the PRIMA-1. Irrespective, what I'm trying to say is, if the patient is a BRCA mutant, especially germline BRCA mutant, the HRD positivity is there, the PARP inhibitors have to be used, and they have shown a very, very good PFS benefit, and some have also, and few have also shown the OS benefit also. So see, these are things to be done in patients who are HRD positive or the BRCA mutation positive. Next slide. So. So these they have done some cross trial comparison between between these arms, between Lynparza and monotherapy and plus Lynparza plus BEV into this study. Although this is not right to compare this trial, but they have shown that there is a concordance between these trials, and the benefit is there in both the arms, whether it's the POLA1 or the FOLA1. They all have shown the benefit with this couplet. Next slide. So what are you considering deciding a specific PARP inhibitor for advanced ovarian cancer? Next slide. So what I'm trying to ask is, do you have your preferences regarding olaparib or rucaparib? These two are only molecule. We don't have niraparib or talazoparib available. So any preference between olaparib or rucaparib, or your personal preference, or what you have seen in clinical practice? Anybody who has preference regarding ola as compared to ruca, or ruca as compared to ola? Anybody?
So I used only olaparib. Still, my experience with rucaparib is not that great. So olaparib I used for 10 patients. I have seen the good responses also, then bad happenings also. Still, it's a way to go forward. I stick on with the olaparib. So in my practice, I never integrated rucaparib as of now.
And Jatin sir, do you start with olaparib at full dose in our patients, or do you start with we have an escalating approach?
Yeah, I don't start with full dose and then de-escalate because I have not been comfortable with that. I've tried in one or two patients and that have backfired, and they discontinued the drug altogether. So I gradually escalate, but I mean they within 2-3 months I am able to reach nearly full dose, and then they are able to tolerate. So I don't know. I mean, people say that you should start with full dose and then de-escalate, but on the contrary, I do the reverse.
I agree, sir. I never started full dose. I've started in a few patients and I've burned my food. I started 50% dose of olaparib, and for that matter, even for rucaparib also, I'm using around 8 to 10 patients. I never started full dose. They post chemotherapy. Personally, a post chemotherapy when the bone marrow reserve is already low, and we start these drugs, we have to be very, very cautious. We have to be very, very cautious.
Yeah.
So
True.
next few slides will be regarding this. These slides already discussed with Dr. Panika regarding the persistent adherence. They are best with the olaparib. Next slide. And this is the standard systematic treatment algorithm, which we all know. Next slide. So next few slide, I won't be taking the slide. I'll just be discussing the side effect. And these drugs, their primary side effects is the hematological toxicity. And especially with the rucaparib, I have seen more of the hematological toxicity as compared to olaparib. And how to manage. I'll just skip the few slides and just try to ask you people, how do you take into what all you see in once the patient has a grade 2, grade 3 anemia or neutropenia, not neutropenia, primarily thrombocytopenia anemia, what do you all consider doing? I want to ask is whether you go and testing for the any vitamin deficiency, or you go in to see for any other test to see whether the patient can be we can still continue the same dose, or you do the dose reduction. I want to ask, how do you navigate the process once the patient has, after 1 month of olaparib, the patient has a grade 3 anemia? How do you proceed? Anybody?
My practice usually I see the MCV and MCH.
Yes, very important. Very important in our setting. Very important.
That's the first thing I used to do. Then based on that, top up with vitamin D or vitamin B12 or iron studies based on the MCV MCH. I will just go navigate that.
This is very important in our setting, in Indian setting, because many of our patients are already nutrition deprived and post chemotherapy reserves are already low. And I always do all this testing, iron, B12, and the transient saturation before giving olaparib or rucaparib. And regarding the management of other effects like the GI toxicity, fatigue is very important side effect of these drugs, especially olaparib. It's a very, very important side effect. And many patients, they say that, sir, we don't have that much of complication during the chemotherapy, but now I'm feeling very low. And fatigue is one thing which has to be taken into account. And again, all the vitamin D deficiency and other vitamin deficiency has to be taken into account. Next slide. I think this can be skipped. Next slide. Next slide. Regarding nausea and vomiting, the patient can be counseled regarding how to take this drug. We can use all the oral medications which are available, but if still the patient doesn't gain much of the benefit, then we have to reduce the dose. Next slide. Again, for the same thing, regarding that, we have to counsel the patient regarding all these side effects. Next slide. Same with the fatigue and asthenia. We have to counsel the patient that these side effects will come down with time, and most of the time after 3 to 4 months of therapy, these side effects, they come down a lot. Next slide. So regarding summary, we all know the AR are commonly experienced with the Lynparza are mostly grade 1 and grade 2, but of course we can see grade 3 for toxicity in around 20-25% patient, and we have to counsel the patient, and we have to keep a very watchful eye regarding the AI. adverse events, and we have to treat them accordingly, as far as the dose reduction is concerned, or to give any supportive treatment. Next slide. So I think we are already out way past our routine time. So thank you, sir.
Yeah.
Thank you so much.
Thank you, Devinder, for doing justice to such a long topic discussion. So I just want to conclude in just one or two lines. First of all, I want to really thank all my participants, all the speakers, and all the panelists, all the both the moderator for their active participation and good discussion. And PARP inhibitors are a very important drugs in our armamentarium. And just like any other drug, we are still having a learning curve. The important thing is testing. We have to choose our patient wisely so that the benefit is there in the patients. The best benefit can be made available to the patient. What I have seen is that the earlier usage is having much more benefit and also less of the side effects. So, but we have to have our own experience. And Indian patients are totally different. We have a real world phase 4 study, which Chitresh alluded to. And I think we can have still more phase 4 studies. And for ovarian cancer, I would say this is a second holy grail after platinum. Such a dismal prognosis of ovarian cancer, and these wonderful drugs have led to PFS and OS in ranges unprecedented PFS, I would say, I've seen. And so is in a bad subset of breast cancer, that is triple negative breast cancer. How it would be integrated with the other newer molecules is yet to be ascertained, and the data is coming. But it was a lively discussion, and I thank once again to all the participants. And also, I thank all my sponsors for facilitating this particular meet. Thank you. Over to the organizers.
Thank you, sir.
Thank you. Should we call it a day?
Yes, sir.
Yeah. Thank you. It is a long day. Thank you.
Yeah.
Good night.